Hello, in this recording, I'm continuing on with the topic of hematologic disorders, continuing on talking about those disorders that affect red blood cells. We will also look at disorders that affect white blood cells. Continuing on with our topic of anemia, we're going to look at hemolytic disease of the newborn. So this affects newborns. This is an acquired condition and it's congenital, meaning the baby is born with it. Hemolytic means the destruction of red blood cells, and this can lead to anemia. It is an alloimmune disease, in which case the mother or the maternal blood and the fetal blood are antigenically incompatible. And so the mother produces antibodies against the baby's blood. And I'll give you a reminder of blood typing after. The majority of causes are due to ABO incompatibility, which occurs if the mother and the fetus have different ABO blood types. But overall, so this will occur in about 20 to 25% of pregnancy, but only about 10% of these will lead to hemolytic disease of the newborn. RH incompatibility, which I'll also talk to you about in a moment, this occurs in less than 10% of pregnancies, and this is the one that is more serious, and that's why I'm going to focus on that in one of our upcoming slides. And this occurs with a second or later pregnancy with an incompatible baby, and that should make more sense once we explain blood typing. So I don't want you to worry too much about writing everything down that I'm saying here. I just need you to understand how this works so that we can apply it to hemolytic disease of the newborn. Our blood, red blood cells, possess different antigens on their surfaces. If someone possesses A antigens on the surface of their red blood cells, then they have type A blood. If they possess B antigens, they have type B blood. If they have both A and B antigens, then they have type AB blood. And if they have neither A nor B antigens, then they have type O blood. Think of an antigen as being like a cellular tag or a name tag that says, hi, I'm type A blood, hi, I'm type B blood, and so on and so forth. Somebody with, for example, type A blood will possess antibodies in their plasma for the opposite blood type. So someone with type A blood, they have the A antigen, but they have B antibodies circulating in their plasma. These are here to fight off type B blood should it enter the body. Type B blood with those B antigens is going to have type A antibody in the plasma to fight off type A blood should it enter that person. Type AB blood has both A and B antigens, and so it should make sense that it won't have any antibodies within the plasma for type A or B, or it would attack itself. Type O blood doesn't have A or B antigens, so it has both antibodies. And so this needs to be considered for the purposes of donation, and you can use this chart on your own to help explain it, but to continue on from where I am, if somebody with type A blood that has these B antibodies needs blood and type B is given to them, the antibodies are going to attach to the B antigen found on the red blood cell and cause clumping within the body. And it's called agglutination, and that can be life-threatening. Similarly, if somebody has type B blood and they need a blood transfusion, they've been in an accident and they've lost blood, if you give that person type A blood, the A antibodies found in their plasma are going to attack. Think of these guys as like soldiers that are sitting around in the plasma waiting for this blood to come in so it can attack it. It will attack the type A blood, the red blood cells, causing clumping or agglutination, and you can see the instances of clumping shown in these petri dishes in certain examples. If somebody has type AB blood and they need to have blood, well, they don't have any antibodies to be concerned about, so you can donate any blood type. This is a very accepting blood type. And that's why it's called the universal recipient, because it can accept A, B, or O blood, because it doesn't really care. It doesn't have any soldiers waiting around in the plasma to fight it off. Type O blood, on the other hand, if somebody with type O blood needs more blood because they've had hemorrhaging, they have both A and B antibodies, A and B soldiers waiting around in the plasma. So if you give that person A, B, or AB blood, the soldiers in their blood will attack it and cause that agglutination or clumping. So people with type O blood can only accept type O blood for the reasons I just explained. Now that's from an acceptance perspective, receiving blood. What about donation if you flip it around? Well, donation has to do with what's on those red blood cells. So to donate type A blood, you have to make sure that the person that you're donating to isn't going to have antibodies against that blood type, similar for B and similar for A, B. But with type O blood, there are no antigens. And so it doesn't matter who you donate type O blood to, because it doesn't have any name tags that identify it as being A or B. And that's why type O blood is considered to be the universal donor. So there is one more variable to introduce, and that's the variable of Rh factor. Rh factor is an additional name tag that some people have on their red blood cells. So let's go back down here and use this as our example. I mentioned already that people with type A blood are going to have the name tag, the antigen A, and we can see that in this example here. Sometimes people have an additional antigen called the Rh factor. People that have the Rh factor just have an additional antigen, and because they possess it, that makes them positive. So somebody that is A positive has both the A antigen and the Rh antigen, making them positive. Now, somebody with type A blood that just doesn't have the antigen is negative. They just don't have it. And that would be the same for our other types of blood as well. And what you can see from this is that somebody with type O blood that doesn't have A or B antigens, if they have the Rh factor, then even though they don't have A and B antigens, they still have the Rh antigen if they're positive. So this is another important consideration now for donations. But here's what's interesting. When it comes to type A, B, and O blood, where antibodies are present for the opposite blood type, this is naturally occurring. These are always there. When it comes to Rh factor, though, you might wonder if somebody doesn't have the Rh antigen. You might think, okay, well then they would have the Rh antibody in their plasma. But that's something different when it comes to Rh factor. Rh antibodies are not present unless the person that is Rh negative comes into contact with Rh positive blood. And this introduces the idea behind hemolytic disease of a newborn. So let me give you an example, and I really want you to try to listen to understand this. Let's say we have a situation where I am pregnant and I have type A negative blood. What that means is that I have the A antigen on the surface of my red blood cells. I also have the B antibodies present within my plasma. But I'm negative. That means I do not have Rh factor or the Rh antigen on my red blood cells. It's just not there. But I also don't have any antibodies against Rh. we can assume that my body knows nothing about Rh factor. My husband, let's say he is A positive. That means that he has the A antigen on his red blood cells, but he also has the Rh antigen. We conceive a child, and that child that I'm pregnant with takes on his blood type and is A positive. So I'm A negative, my baby is A positive. Normally, with maternal circulation, my blood will enter the baby's blood. And that's okay, that's not a problem. Because the baby's blood isn't going to be entering my body. However, at birth, there is mixing of blood. And some of that baby's positive blood, Rh positive blood, is going to enter my body. When my body looks at the red blood cells from the baby that have come into contact with my blood, it's going to say, okay, one, I recognize the A blood type, so that's okay. But what is this Rh factor? What's this positive antigen? I'm not sure I like it, so what I'm going to do is I'm going to produce Rh antibodies against it. And that's not going to matter at that point because the baby's already born. But now what I have in my body is my regular A negative blood, but now I have Rh antibodies. So let's say I decide not to have any more children. No problem. But if I ever need a blood transfusion, I can't receive positive blood because I have antibodies against it. But when it comes to hemolytic disease of the newborn, let's now assume I get pregnant again and the baby is also A positive. And the maternal blood, my blood, is going to be entering the fetal circulation. What's going to happen during that pregnancy is my blood with the Rh antibodies is going to enter the baby and cause really an attack on the baby's red blood cells. And this causes hemolysis of the baby's red blood cells. The baby will break down those red blood cells at a faster rate that it can handle it. And when the hemoglobin breaks down, we end up with a byproduct of bilirubin. And this can lead to hyperbilirubinemia, which can cause icterus or yellowing of the skin, jaundice in the baby. And the baby will need to be treated and watched very closely after birth in order to clear out this excess bilirubin. Sometimes these babies will even need transfusions. So it's an important clinical consideration when women get pregnant is what is their blood type and what is the possible blood type of their baby. Hemolytic disease of the newborn can be prevented. Almost all women will have a blood test to learn their blood type early in pregnancy, but if there isn't access to health care or poor resources in developing worlds, this can be a challenge. So if the mother to be is Rh negative and she does not have the antibodies within her blood, she'll be given a medicine during her pregnancy called Rh immunoglobulin in order to prevent the formation of antibodies, because once you have them, you can't get rid of them. So for short, it's called RhoGAM, RHOGAM, Rh immunoglobulin. And so this medicine will stop her body from producing antibodies as a reaction to the baby's Rh positive cells. And then if the baby is in fact Rh positive, then another dose will be given within 72 hours of giving birth in order to, again, prevent the formation of antibodies. And this way, if there's a second pregnancy, there isn't concern of attacking the baby's blood if the baby is in fact positive. And also, then there isn't an issue with a transfusion of positive blood should the mother need it. And phototherapy or light therapy is another treatment that will be done in babies that do have hemolytic disease of the newborn. But in certain situations, these babies won't survive. They may not even make it to term. This is a summary of some of what I've spoken about with the antibodies. The specific antibody is immunoglobulin G that binds to the baby's red blood cells, leading to widespread hemolysis. And the only other thing to mention here is that because there's not enough healthy red blood cells because they've been attacked by the mother's antibodies, the baby's bone marrow will start to release immature red blood cells, so those are commonly seen within the blood. So at this point, we've spoken so much about different forms of anemia, and I'm going to speak generally about some of the compensation mechanisms that exist for anemia. So you don't have to write this part down, but anemia that is mild and develops gradually is usually easier to compensate for and may only cause problems for an individual when they're physically exerting themselves. That's when they'll notice, I'm really tired and I don't have the energy to do this. With certain anemias, as the reduction in red blood cells continues, symptoms can become more pronounced and alterations of specific organs and compensatory effects become more apparent. Compensation is going to generally involve the hematologic, cardiovascular, respiratory systems, and the kidneys can also play a role. In the hematologic system, what we see is that when there's less red blood cells, blood is actually thinner. And so it's going to move faster and much more turbulently, leading to what's called a hyperdynamic circulatory state. Within the cardiovascular system, there can be an increase in stroke volume and heart rate to help compensate for the reduction in oxygen. So the heart tries to beat faster and pump out more blood volume. So this is cardiac output in order to deliver oxygen to tissues. But this strain on the heart can lead to what's called cardiac dilatation and insufficiency of the heart valves. Cardiac dilatation refers to the ventricle stretching and thinning, and then when they get to that point, they're not able to pump blood properly. And heart valve insufficiency refers to regurgitation or leaking of blood instead of it moving in a one-way direction from chamber to out of the heart. It can backflow. The respiratory system, the body will adjust to increase the rate and depth of breathing in order to increase oxygen availability. The kidneys will also respond with an increase in the release of erythropoietin in order to increase red blood cell production, which we already know. And there'll also be an increase in salt and water retention. And what this will do is it's a compensatory mechanism that adds more fluid or volume into the blood vessels, and that will ultimately increase blood pressure. So the body's trying to compensate, but it ultimately is going to cause other problems. And these compensatory mechanisms, even in the most mild cases, can cause shortness of breath, a rapid and pounding heartbeat, dizziness, and fatigue. And this is what you'd be more likely to see in somebody who has anemia, but it's mild enough and they usually feel okay, but then they exert themselves, and that's when the compensatory mechanisms start to kick in to control for that, but it can lead to uncomfortable side effects. But in those with more severe states of anemia, when these compensatory mechanisms are working even at rest. I also wanted to mention that because of the increase in stroke volume, so putting a greater volume of blood into the circulatory system, and also increase in the amount of water that is going to contribute to the plasma as part of our blood, this also contributes to a hyperdynamic circulatory state. This is our final slide, really wrapping up our discussions on anemia, and it summarizes a lot of what we looked at. But I want you to really think of anemia as an umbrella term in that there are so many different types of anemia, and we didn't even cover all the detail. So many different types and different severities. And So what we do know, though, is that the main physiologic event or manifestation of anemia is going to be this reduction in oxygen carrying capacity, which we can call hypoxemia. Emia is blood, so this is low oxygen in the blood, which is then going to lead to tissue hypoxia. And that will bring on a whole array of potential signs and symptoms. Compensatory mechanisms, as introduced to you on the previous slide, are going to kick in, which can also bring about a whole array of signs and symptoms. But what I did want to point out to you that is new is this here, DPG. There'll be an increase in DPG in cells. What is DPG? It stands for diphosphoglycerate, and this is found primarily in red blood cells. And what it will do is it will promote the release of oxygen molecules bound to hemoglobin. So it really enhances the ability of a red blood cell to release its oxygen near tissues that need it the most. Because we know if we're in a state of tissue hypoxia, we need to get as much of that oxygen that is on the red blood cells off the red blood cells and into the tissues so that they can use it. And so this increased activity of dysphosphoglycerate in cells will promote that increased release of oxygen that's bound to hemoglobin, bringing it into the tissues. We've spent quite a bit of time now talking about anemias, and now we're going to talk about polycythemia. Poly means many. With polycythemia, this is where there is an excess in the amount of erythrocytes within whole blood. There's relative forms and absolute. Relative polycythemia is caused by dehydration. It results from hemoconcentration of the blood from fluid loss. And so what we'll see is an increase in the amount of red blood cells, an increase in the amount of hemoglobin, and an increase in hematocrit value. Hematocrit is the ratio of the volume of red blood cells to the total volume of blood. Now, what can cause this state of dehydration leading to relative polycythemia? Well, it could be a reduction in water intake, diarrhea, excessive vomiting, maybe somebody's using diuretics, which encourage loss of fluid through the kidneys. And its development is usually of minor consequence and can resolve with the administration of fluid or treatment of the underlying condition that led to it to begin with. So that's relative polycythemia. It appears that there are more red blood cells than are considered normal, but that's just because there is less water making up the plasma of whole blood. And so this example here is polycythemia. Looks like there's a lot of red blood cells, but it's because there's less plasma compared to normal. Now, absolute polycythemia has two forms: primary absolute, which is also known as polycythemia vera, and secondary absolute. Primary absolute is an abnormality having to do with stem cells in bone marrow. And so this would be less common than secondary absolute, but this abnormality causes the overproduction of red blood cells because of a problem with the cells that produce red blood cells within the bone marrow. Secondary absolute is either going to be physiologic or pathologic in terms of its cause. What we'll see with either case, though, is that the reason we're producing more red blood cells is because of chronic hypoxia. So the body is in a state of not getting as much oxygen as it needs, and so the response to this is to produce erythropoietin to then stimulate the red bone marrow to make more red blood cells in response to this chronic hypoxia. And so it's like the body thinks, we're not getting enough oxygen for some reason, so let's just make more red blood cells to try and account for that. Physiologic is seen when people move to places of high altitude where less oxygen is available, so the body responds by producing more red blood cells to try and compensate for that. Pathological causes include smoking, chronic obstructive pulmonary disease, as well as congestive heart failure. With this habit and with these conditions, the body is in a chronic state of hypoxia, causing the body to produce more red blood cells. Secondary absolute polycythemia can also be seen when certain tumors that we can call erythropoietin secreting tumors secrete high amounts of this hormone, stimulating the bone marrow to make more red blood cells. On this slide, we're going to look at some of the major complications that can occur with polycythemia vera, remembering that that is a form of absolute polycythemia, specifically primary absolute. And I said it involves the stem cells. This is technically a slow developing cancer. Now, even though I'm speaking of polycythemia vera on this slide, really these events can occur with any state of polycythemia. It's dangerous for our body to produce too many red blood cells. When we have an increase in the amount of red blood cells, it makes our blood thicker. Thicker blood will move slower through the body and is more likely to develop clots, a state of thrombosis. Clots can cause occlusion or blocking of blood vessels, which can lead to, depending on the state of the clot, ischemia, as well as infarction. Treatment of polycythemia vera specifically is quite challenging, and it's directed towards minimizing the risk of thrombosis and preventing progression. In people that are considered to be lower risk, the recommended therapy is phlebotomy or therapeutic phlebotomy, as well as low-dose aspirin. Therapeutic phlebotomy involves removing blood, and aspirin will help with preventing the formation of clots because of its antithrombotic properties. There's also medications that can be given to prevent the overproduction of the red blood cells at the level of the bone marrow. However, the trouble with this is when you're stimulating the bone marrow to produce less blood cells, you're also going to get a reduction in white blood cells and platelets. Moving on now from our discussions on erythrocytes, we're going to look at leukocytes, which are white blood cells. Leuc means white. There are two types of disorders involving alterations or changes in leukocytes, quantitative disorders and qualitative disorders. One has to do with the quantity of white blood cells, and the other has to do with the quality. Quantitative disorders include leukocytosis, which is an increase in the number of white blood cells relative to normal, and leukopenia is a reduction in the number of white blood cells compared to normal. Qualitative disorders include leukemia and lymphoma. Before we elaborate on those, I wanted to remind you of our white blood cells. What we have are these 5 main white blood cells here. Basophils, eosinophils, and neutrophils are collectively referred to as granulocytes because they have, when stained, there are granules evident within their cytoplasm, and those granules can release very specific substances. Monocytes and lymphocytes are considered agranulocytes, meaning they don't have granules present within their cytoplasm when they're stained. So these are the 5 listed here. And so just keep those in mind while we look at the specifics. So we'll look at quantitative disorders, looking first at leukocytosis, which we know is an increase in the amount of white blood cells. There are different forms. Granulocytosis is an increase in granulocytes. So thinking back to the last slide, that would be your neutrophils, eosinophils, and basophils. However, because neutrophils are the most numerous of the white blood cells, what will oftentimes be seen is a larger increase in neutrophils, and so sometimes it's called neutrophilia. So this is the most common form of leukocytosis. This and what happens when there's this big increase in white blood cells is that stored white blood cells are released into the circulation. Now, neutrophilia can be seen in especially the early stages of infection or inflammation, but we only have so many ready-made mature neutrophils. And so when the demand for circulating mature neutrophils exceeds the supply, then immature neutrophils and other white blood cells are going to be released from bone marrow. Premature release of the immature cells is responsible for a phenomenon, microscopic phenomenon, known as shift to the left. So this refers to microscopic detection of this disproportionate number of immature leukocytes that would be seen on a blood smear. Now, once the bacterial infection and inflammation is under control, then you would see a shift to the right as the numbers return to normal. Now, if there is an increase specifically in eosinophils, it's called eosinophilia, and this is more commonly seen with allergies. So let's say, for example, somebody is sensitive to dairy and they have some milk and then it brings upon eczema. They may have an increase in eosinophils present because of this. Eosinophilia can also be seen with parasitic infections. Another example is lymphocytosis. Lymphocytosis is an increase in the amount of lymphocytes in the blood, and this is more commonly seen with an acute viral infection such as the Epstein-Barr virus, which causes infectious mononucleosis, or the abbreviation known as mono. There are other examples, but these are some main ones that I want you to be aware of. And then with leukopenia, where we see a reduction in the amount of white blood cells, our first example here is really the opposite of what we've seen up here, which is granulocytopenia. The cause of a reduction in the amount of white blood cells is numerous, but some examples include a prolonged infection. The infection is lasting a long time, and we need more than we're actually able to produce. There's also situations where there might be reduced production. Certain drugs, chemotherapy, radiation can affect the bone marrow's production of white blood cells. There also may be a situation where the white blood cells that are released into the circulation are not surviving as long as they should. Next up is agranulocytopenia. This is really the complete absence of granulocytes in the blood, so that A in front is lack of. And where this would be seen is secondary to the stoppage of hematopoiesis, which is the formation of blood cells in bone marrow. Or maybe there's massive cell destruction within the circulation. Those are just examples. And chemotherapy can also cause substantial suppression of bone marrow. Lymphocytopenia is a reduction in the amount of lymphocytes. This would be most commonly seen with immune deficiencies such as AIDS. It can be seen as well with chemotherapy and radiation treatment. But please note that this is not an exhaustive list. There are many other examples. This is just to give you an idea of some. Moving on to a particular infection that I mentioned on the last slide called infectious mononucleosis. This is best described as an acute infection of B lymphocytes, causing what we already said is lymphocytosis, an increase in the number of white blood cells. This is a viral infection caused by the Epstein-Barr virus that is transmitted usually by saliva or mucosal secretions. And a person is usually going to be infected during adolescence or later. 30 to 50% of people that contract Epstein-Barr virus will develop infectious mononucleosis. Sometimes it's also called the kissing disease. But younger children, if they get this virus, it usually does not develop mononucleosis, so it can be seen more often in, for example, university settings. B lymphocytes, remember, are involved in antibody production. Clinical manifestations include fever, sore throat, effects on the lymphatic system, including swollen cervical lymph nodes. We know that there would be an increased lymphocyte count, and there would also be an increase in the number of atypical lymphocytes. Because this condition does involve proliferation within the lymphoid tissue, for example, within the spleen, it could, in rare cases, lead to splenic rupture. but that would be unlikely to occur. Okay, now we'll move on to the qualitative disorders of white blood cells, including lymphomas and leukemias, and we'll look at the difference between the two. Leukemia is a cancer of white blood cells. Usually there is this excessive accumulation of leukemic cells, which are atypical white blood cells. There are different types that exist, including acute and chronic, as well as myeloblastic and lymphoblastic. We'll come back to this though. With lymphoma, this is cancer of the lymphocytes. And there are two types that I'm sure you've heard of, Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's is typically easier to treat with a higher survival rate, whereas non-Hodgkin's lymphoma is more aggressive and more difficult to treat and therefore has a lower survival rate. Looking back now at leukemias, we'll differentiate between acute and chronic forms. Both acute and chronic forms of leukemia can exist as lymphocytic or myelogenous. Lymphocytic or myelogenous. So what does that mean? Well, let's have a look here. If we look at this pluripotent stem cell that can differentiate into a variety of different things, we have myeloid and lymphoid arms. The myeloid are going to differentiate into eosinophils, monocytes and macrophages, neutrophils, and basophils. So those all originate from the common myeloid stem cell. And so that is what the myelogenous leukemia will affect in both acute and chronic forms. This other arm is the common lymphoid stem cell, which will differentiate into our B lymphocytes, natural killer cells, and T lymphocytes. And you can see here that the B lymphocytes will form plasma cells, and these T lymphocytes form our T cells. And so these guys here are impacted then by lymphocytic leukemias. So that's the difference between lymphocytic versus myelogenous forms. But what's the difference between acute and chronic? Individuals with acute leukemias will have a higher number of immature or undifferentiated cells. Those with chronic leukemia, on the other hand, will have a higher number of mature cells, but they don't function normally. So the mature cells will get the name, you'll oftentimes see sites as the suffix, whereas immature or undifferentiated cells, you'll see the term blast. Now in both cases, acute versus chronic, the cells are atypical and they don't function properly. But the difference really between acute versus chronic is really relating to the stage that the cell is in, the white blood cell, in its process of differentiation. Now you do need to be aware that ALL, acute lymphocytic leukemia, is the most common form of leukemia in children, whereas acute myelogenous leukemia and chronic lymphocytic leukemia are the most common in adults. You may recall as well from our genetics lecture when I spoke about Philadelphia chromosome with translocation that it can cause somebody to develop chronic myelogenous leukemia. Let's look at some general features looking at leukemia as sort of an umbrella term. What we see is uncontrolled proliferation of cancerous or malignant white blood cells. And this causes an overcrowding within bone marrow. And this overcrowding in bone marrow can cause a reduction in the production of normal cells going forward. Hematopoietic cells are cells that have the ability to form blood cells. So what this can lead to is a condition called pancytopenia. Pancytopenia is a deficiency in all three of the main cellular components of blood: red blood cells, white blood cells, and platelets. So once again, the overcrowding in bone marrow can cause the normal hematopoietic cells that can produce white blood cells, red blood cells, and platelets, can cause these cells to not function properly in terms of what they can produce, and we end up then with a reduction in all three of those cell types, leading to what's called pancytopenia. And so as you can imagine then, if there's a reduction in red blood cells, it can lead to anemia. If there's a reduction in your clotting cells, it can lead to what's called thrombocytopenia. And if there's a reduction in white blood cells, it can lead to leukopenia. So many different effects coming out of the leukemic state. So a little bit more still on leukemia. The abnormal leukemic cells can infiltrate other tissues in the body, specifically the liver, spleen, and the lymph nodes, causing them to enlarge. In acute leukemia, it can infiltrate the bone, and it can cause bone pain, which is mentioned down here. I mentioned on the previous slide that it can lead to pancytopenia, including a reduction in red blood cells. So this can lead to anemia, presenting with fatigue and pallor, that unhealthy pale appearance. The rapid breakdown of these leukemic cells can lead to a buildup of uric acid in the blood called hyperuricemia, and this can lead to gouty arthritis, where the uric acid accumulates within joints and causes pain. So this is a fairly common effect. Anorexia is common as well. Loss of taste and lack of appetite can lead to weight loss. We know that the production of healthy white blood cells can be suppressed. This makes somebody with leukemia less likely to be able to fight off an infection that otherwise you would be able to, which can lead to a low-grade fever as the body is trying to fight off the infection, but may not be easily successful in doing that. It's not entirely uncommon for those with acute leukemia to develop two different types of disorders of platelets, one being thrombocytopenia, a term I mentioned earlier that is part of that umbrella term pancytopenia, where you're not producing as many platelets, and so the ability to clot is reduced. In other cases, there can be an increase in the production of platelets, leading to an increased likelihood that clots will form. There's also a condition that we'll talk about in a bit called disseminated intravascular coagulation, which involves widespread clotting throughout the body. I spoke about the bone pain already, but leukemic cells can also infiltrate the central nervous system and cause damage to the brain. Acute leukemia is known to come on very abruptly and rapidly, and without treatment, the disease progression will result in short survival time. Chronic leukemia advances more slowly and insidiously, and an insidious disease is one that comes on slowly, but it doesn't really have any obvious symptoms at first, so it's developing and the person isn't aware that it's developing because there aren't real specific signs or symptoms that would lead to the concern of chronic leukemia. Let's move on now and talk about alterations in lymphatic function. The term lymphadenopathy is when lymph nodes enlarge enough that they become palpable, meaning you can feel them. They become tender. They might be local to one area, or they could be generalized throughout the body. We can see some swelling here. This is an example of lymphadenopathy. You can see it a bit in the axillary region as well, and then most certainly within the groin. There are different causes, including neoplastic disease. So this is where an abnormal mass of tissue forms when cells grow and divide more than they should. Certain immunologic or inflammatory conditions can predispose somebody to lymphadenopathy, certain endocrine disorders, as well as lipid storage diseases. Malignant lymphomas are much more concerning. They include Hodgkin's lymphoma and non-Hodgkin's lymphoma, and it involves the malignant transformation or change of lymphocytes. It involves the proliferation of lymphocytes, and this occurs within the lymph nodes. And it leads to crowding. It can progress from one lymph organ to another lymph organ. The condition is staged from 1 to 4 depending on the number of lymph nodes that are involved and the extent of the spread. And don't forget, earlier we did speak a little bit about some of the differences between the two. We're going to move on now and talk about hemostasis. Hemostasis is your body's normal reaction to some injury that causes bleeding. And the reaction, the hemostasis, is going to be to stop the bleeding from continuing to occur and allow for healing. The 3 stages, speaking generally, include a formation of a platelet plug, then a formation of a clot, and then dissolution of that clot. And the contributing organs include bone marrow, which produces, we know, blood cells, including platelets that are also known as thrombocytes, and the liver, which produces the factors that are necessary in order to actually form a clot. And if you're missing any of these factors, it could impact your ability to produce a clot. So not only do you need your bone marrow to properly produce platelets, you also need your liver functioning to produce clotting factors. So naturally then, because of the direction that we go with this course, is that sometimes clotting mechanisms can be impaired. And the 4 main causes as to why somebody cannot properly form a clot include vitamin K deficiency, liver disease, thrombocytopenia, and hemophilia. Certain clotting factors, shown here in green, require vitamin K in order to function. And so lack of vitamin K or deficiency means that some of the clotting factors aren't going to be able to function properly. Why might somebody have a vitamin K deficiency? It can be related to malnutrition, so not consuming enough, or malabsorption. Bacteria within the large intestine can produce some vitamin K as well. So not entirely dependent on it in the diet. The liver, as we know, produces clotting factors. And if somebody has cirrhosis or liver failure and can't properly produce these clotting factors, then it can reduce coagulation or clotting. Thrombocytopenia is a reduction in the amount of platelets or thrombocytes. This state can occur because either somebody isn't producing enough or their body is consuming or utilizing more than are being replaced. Hemophilia is another cause of impaired hemostasis. Because people with this inherited condition do not produce enough clotting factors, they have difficulty with clotting. And there are different forms of hemophilia where different factors are affected. I mentioned this term already, disseminated intravascular coagulation, or DIC. This is a complex acquired disorder that is primarily initiated by endothelial damage. Remember that the endothelium is the epithelial layer that lines our blood vessels. And what I mean by this is that it's this condition that ends up leading to DIC. What we see with DIC is simultaneous clotting and hemorrhaging occurring because of altered thrombin, fibrin, and fibrinolysis physiology. And we'll discuss a bit more of that on the next slide. Clinical manifestations include bleeding from venipuncture sites, so if somebody's having blood withdrawn from veins, bleeding from arterial lines, this is if a line is placed into an artery for easy sampling of blood. Purpura, which is purple-colored spots and patches that can occur on the skin and in the mucous membranes, including within the lining of the mouth. And petechia, which are these pinpoint round spots that appear on the skin and as a result of bleeding. And hematoma, so that's, we know, is an area of clotted blood outside of a blood vessel. Symmetric cyanosis of the fingers and toes can occur, which is a bluish color of the skin. And that's because there's been a reduction in proper oxygenation to those distal parts of the body. Now, treatment is to remove the stimulus or the whatever condition is occurring in order to resolve the disseminated intravascular coagulation. A little bit more on disseminated intravascular coagulation. So some sort of stimulus, whatever the condition is that causes the DIC. What we're going to see is unregulated activation of thrombin. Thrombin is the factor that causes the formation of fibrin, which creates the mesh that forms the plug. This happens everywhere. In other words, the thrombin does not remain localized. It's happening throughout the body. Now, normally it would just be in one area, but instead we're seeing this throughout. Now, our body possesses antithrombins that prevent overclotting, but in disseminated intravascular coagulation, the thrombin exceeds the antithrombin's ability to effectively slow down the clotting. Multiple clots are going to form all throughout the body. And so you could probably appreciate now that we're going to have this high consumption of clotting factors and platelets. And then the clots have to break down. And the meshes break down. That's called fibrinolysis. Accelerated fibrinolysis can lead to hemorrhaging. We've lost and used up a lot of the clotting factors and platelets already. This can lead to widespread ischemia. It can lead to organ hypoperfusion, where organs are not being perfused properly with the blood that they need for survival, which can lead to an infarction. And if it's not treated quick enough, then it can lead to multi-organ dysfunction syndrome, so multiple organs being affected by this condition. And the end result can be death. Okay, that's the end of this lecture. Thank you for your time. Bye for now.